I think so far it's been very good. We have got a good understanding of autonomic dysfunction in spinal cord injury patients. So something for us to consider in our regular trauma patients coming in with spinal cord injury and hypertension. And we have to think of another perspective also, which is autonomic dysfunction, right? AD. So I think that was very enlightening. So I also practice trauma in our center very heavily, and yeah, something that I can put into practice. Our next talk is a step-based approach towards myopathic disorders. Let's do this right. So I think again is extremely relevant to our emergency setting. Okay, we see patients with myopathies presenting to us, but maybe sometimes our approach is not there. Or is there really an approach? Do many of us emergency physicians really have an approach to myopathic disorders? And if we do, how can we make it right? Yeah. So I think our next speaker will enlighten us a little bit on that. Dr. Mahavishnu Sahadevan. So he is a consultant neurologist at the Hospital Putrajaya. He completed a fellowship in autoimmune neurology at the University of Oxford. He is also a fellow of the European Board of Neurology and the European Stroke Organization. Dr. Vishnu's clinical and academic interests include autoimmune and cognitive neurology. And he is currently leading efforts to establish a center for precision care in neurology in Hospital Putrajaya. A very distinguished speaker and a very relevant topic for us. Please welcome Dr. Vishnu. Please proceed, Doctor. Thank you.
Sorry, yeah. Can you hear me?
Yes, we can hear.
Is my slides sharing? I'm not very sure because I can't see it on my.
It's sharing. We can see the slides.
Okay, wait. Let me just adjust a little bit of that. Okay. So hi, thank you very much for the invitation. I'm going to talk about the approach to myopathy in an emergency setting. It's a very broad topic, so I'll try to make it as easy as possible and make it simpler so that everyone gets an idea and there's something to take home at the end of the day. So before we start, it's always important to know what the definition of myopathy is. So it is basically a disorder affecting the channels, the structure, or the metabolism of a skeletal muscle. So myopathy basically is primary disease of the skeletal muscles, and patients would come in with weakness, some atrophy, sometimes myalgia, cramps, fatigability. And the important thing to note when you see these patients who walk in with muscle weakness is there any upper motor neuron signs? If there is, then it's not a myopathy. And is there sensory loss? Because they usually come without. Okay, so that's basically the broad definition. And as I said, myopathy is so wide that there's so many differential diagnoses, and we'll never know exactly where to start. So I'm going to try and make things a little bit easier so that you know how to approach these patients when they come. When someone comes in and he says, I've got weakness, so I've been weak for a week, or for months I've been weak. What do you do and how do you approach it there? That's what we're going to look at. So before we start the approach per se, there are a few things you need to know. And the first thing, it's called core concepts. So there are some concepts which you need to understand in order to make life a little bit easier when you want to diagnose a patient with myopathy. So the first concept is positive symptoms. We get them in all diseases. In myopathy, is no different. And when we talk about in any disease, a positive symptom basically means something abnormal that appears that shouldn't be there. So in terms of myopathy, it's excessive excitation or loss of inhibition. So if this tends to come in the form of cramps, contractures, myalgia, stiffness, myotonia, myoglobinuria is also a positive symptom. So I'll tell you again later why this is important. It's just to highlight a concept. And then there's something called negative symptoms, which is more common in myopathy. And this usually means, broadly, a loss of function, something that should be there, that is absent. So in the background of myopathy, loss of neuronal activity or failure of conduction is usually what we mean when we say negative symptoms. They may report it such as weakness, fatigability, muscle wasting, and it's basically loss of contractile fibers and motor unit outputs. So that is the first part of the basic concept. The second basic concept of myopathy that you need to know is the pattern. And we have 10 patterns of distribution. So whenever you talk about a weakness, which is originating for the muscles, it usually falls into one of these patterns, and it's very important to know them. So I'll just explain briefly before I come to the approach, because I feel it's important to talk a little bit about it. And the first pattern we get is something called proximal or a limb girdle type of weakness. And this usually relates to the weakness affecting shoulders and the hips and the neck. Those are proximal muscles. Whenever you say proximal, we look at shoulders, hips, and necks. So those are called limb girdle type of weaknesses. And patients might just say, I have difficulty standing up, combing my hair, climbing upstairs. Yeah, then you should suspect a proximal limb girdle type of weakness. And it's very particular types of myopathy presents with this. So I'll talk to you about it a bit later, but now let's just look through the patterns. So like proximal, we have distal weaknesses as well. So distal weaknesses are usually in the upper limbs, lower extremities, and patients would say anything away from your shoulder and hip joints are distal. So whenever you patient would say, I have difficulty walking down the stairs because you need to use a lot of your quadriceps muscles when you come down, when you descend. That's a distal weak. That's a slight clue that there is a distal weakness in this patient, and sometimes it's further distal, like his finger flexions, gripping. So toe clearance is also a common distal weakness. You'd see them having a high stepping gait. It's because of their dorsiflexion and plantar flexions might be involved. So these types of weaknesses, we would classify them as distal weaknesses. And the second type of pattern is proximal arm and distal weakness of the leg. We like to call this scapuloperoneal type of weakness. And in these patients, you tend to see the winging of the scapula, and there's a lot of differentials when they come with this. So when someone comes with proximal weakness, with a distal leg weakness, you would suspect scapuloperoneal, and the differential diagnosis, the most common are these. And something to think about, keep it in the back of your mind. You don't need to memorize any of the differentials. So the fourth type of pattern is distal arm and proximal leg weakness. So when a patient has this type of pattern, you see it very commonly in inclusion body myositis, myotonic dystrophica. Then there are patients who come in with ptosis, ptosis with or without ophthalmoparesis. Ophthalmoparesis, ptosis simply means there's a lid, your eyelids has dropped down, and ophthalmoparesis means you have weakness of your eye muscles. So ptosis, you can see it. Ophthalmoparesis, it's usually identified when you ask him to look left, right, up, down. They would have diplopia. You can suspect ophthalmoparesis, and there's a differential when you see these patients. The differentials are basically without ptosis, you have a lot. With ptosis, when you have ptosis with ophthalmoparesis, you also need to look out for myasthenia gravis, which is a neuromuscular junction problem more than a myopathic problem. So I'll talk to you about those types of diseases as we go along. So this is the fifth pattern we tend to see in general. And then there's a sixth pattern, which is called just the neck extensor weakness. People like to call this the drop head syndrome or head dropping syndrome. And there's a vast majority of these patients who are dermatomyositis, polymyositis, inclusion body. There's a lot of differentials, but sometimes they would just present with a head drop. Then there's something called bulbar weaknesses, which we see, and that's very common in uh, things like limb girdle muscle dystrophy type 1A. And there's some patients may have episodic pain, weakness, and associated myoglobinuria. So when these patients come with episodic pain or episodic weaknesses with a cola-colored urine, dark tea-colored urine, you'd want to ask them, is it related to exercise or is it not related to exercise? Because differentials look a little bit different when it is. So just keep that in mind. And then there's another pattern called episodic weakness, delayed or unrelated to exercise, which is usually a metabolic sort of myopathy. And you see, and some endocrine problems can present this way as well. And last and final pattern is stiffness and the decreased ability to relax. See it very commonly in myotonic dystrophy and Becker's disease, stiff person syndrome, like what Celine Dion has. Yeah, you might see things like this. So these are the patterns we look for when someone comes in and says, I have weakness, maybe in my arms, legs, or wherever. And does it fall in one of these categories? And if it does, we have sort of an idea where to proceed and how to proceed from here. So how do we actually approach a patient with myopathy? So that's what I'm going to tell you right now. Okay, so this is the most important part of it. Okay, so it starts with history. So in history, you need to look out for the positive, negative symptoms like we mentioned. Is there weaknesses, fatigue, muscle wasting? Is there cramps, stiffness, dark-colored urine, which are positive symptoms? Um, the highlighted in red is negative symptoms. You can clarify sometimes. You need to ask them, is it symmetrical? Are both hands involved, both legs involved? And sometimes you might ask them things to know whether, just to get a hint if it's proximal. Is it difficult to comb your hair, climb stairs? If it's distal, is it hard to button your shirt? So these are just hints. So we'll first start off by trying to have a brief idea where the weakness is in our patient. The second thing we need to know is the time course, because when something happens acutely, which is less than a week, it's usually polymyositis, viromyositis, rhabdomyolysis. All the drugs that cause myopathy usually happen within the first week. Subacute is it's a large number which come in with this, and it's mostly autoimmune based, like polymyositis, dermato, inclusion body, immune-mediated necrotizing myositis, um, endocrine drug-induced myopathies can be subacute. Then we have chronic, which happens over the years, which are usually genetic, and it can be Duchenne's muscular dystrophy, Becker's, Charcot-Marie-Tooth. And so they happen in a long months and years, and they may have family history. So whenever it's chronic, look out for the genetic part of it. The next is the characteristic or the character of the weakness. Is that myopathy symmetrical? Are both sides affected? It's always important to find out. Is it more distal? Is it more proximal? Is the neck flexors, neck extensors weak? Are there any ocular or bulbar symptoms? Is there a nasal voice? Is there if it's is there any diplopia? Is there any ptosis? Yeah, so look out for this. Ask them about it in history. Some associated symptoms which are important and whenever someone comes in with weakness, we need to highlight is, are there any skin changes which they report that would suggest dermatomyositis? Is there any dyspnea, any autopnia? There is, you need to suspect a diaphragmatic weakness. So you need to keep a bit more of a closer eye on these patients. Are there any cardiac symptoms, chest pain, palpitations, a syncopal episode? Autonomic symptoms like diaphoresis is also a cardiac issue that you can see from time to time. Any GI problems like dysphagia, regurgitating out of the nose. So that indicates a pharyngeal dysphagia. So that is something you should ask when they come in with weakness, whichever pattern of weakness. We still need to rule out these systems. Are they involved? Any endocrinology type of histories which they present with, like weight loss, weight gain, Cushingoid symptoms, cold intolerance, which may suggest an underlying thyroid disease, which is very common. Any systemic involvement, Raynaud's phenomenon, arthralgia, fevers, malar rash, things like that, which may point you towards a connective tissue disease. So some associated symptoms are always important when you see them in history. Um, we should always include a drug history because these are the most common statins, alcohol, corticosteroids, hydroxychloroquine in SLE patients are also common. Retroviral groups, we tend to not ask them when they come in thinking it's a taboo to task about it. But you need to talk because we missed retroviral patients with myopathy, which is actually just basically drug induced before. Ask them about viral infections. Did they recently have a fever, cough, URTI? Influenzas tend to come with post-viral myositis, so it's good to ask about this in history. And is there any family member which has this similar kinds of problems? It can point you towards an X-linked, an autosomal dominant, a recessive type of condition. Did it happen since he's in childhood? Were there any delayed milestones? All that are clues for genetic causes of myopathy. And of course, the most important I would feel is the functional inquiry. We should always find out what brought him. He may have had weakness for a long time, but something brought him to the hospital. It's because of some function which he was unable to do or she was unable to do. So we should ask about activities which has brought them in. What exactly was the nature? Was it climbing stairs, getting up, combing your hair, some exercise intolerance? So that's in our history. Red flags to look out for when you ask history is if a weakness is rapidly progressing, that's a red flag. If there's a dark cola colored, tea colored, they say TO or something like that, which suggests myoglobinuria, that's also a red flag. Dysphagia, any respiratory symptoms, can be an emergency. You may want to electively intubate them. Weight loss, fever, rash can actually tell you about a flare in a systemic disease like SLE, a paraneoplastic syndrome. So these are red flags which we look out in history. Only four. So now when we ask the history, we suspect it's myopathy, it's weakness in the muscle. The first thing we need to do when we are going to start our examination is we need to localize the weakness and make sure it's coming from the muscle. And before we do that, we must make sure it is a lower motor neuron lesion. So no upper motor neuron signs should be there. For example, spasticity, hyperreflexia, your Babinski's going up, that's all upper motor. If it's there, it's not a myopathy. They don't present with any sensory loss most of the time. They shouldn't have any bladder problems. Bowel problems can be there, but no bladder problems.
Question mark
Yeah.
sila like Mm.
Okay, that is somewhat. I'm not sure what that was in the background. Okay, thank God it's gone now. So there's also fatigability and diurnal fluctuation. So you should make sure that these symptoms don't fluctuate because when they fluctuate, it always points to the NMJ, the neuromuscular junction. So whenever it fluctuates 90% of the time, it is most likely myasthenia gravis. So keep that in the back of your mind when you see patients who come in with weakness. Okay. The clue you want to see is if the weakness is symmetrical, proximal is usually very much more common. Are the reflexes preserved? Is the sensation intact? If all these things are there, you can very much say it sounds myopathic. So that's our first step. The second step is to localize it. We know it's a lower motor neuron lesion. Where is the lesion? That's the question we'd ask. So it can either be in the anterior horn cell, the peripheral nerve, the neuromuscular junction, or the muscle itself. So if it's in the anterior horn cell, you might see other signs like fasciculations. The reflexes may be absent or reduced. Sensations are usually preserved. Wasting is a little bit more common, especially in the hands. You've got to look at the hands for them. If it's a peripheral nerve problem, the distal is usually more affected than the proximal, and they would have a sensory loss, and it's usually in the glove and stocking distribution. If it's a neuromuscular junction, like I told you just now, there might be fluctuations. Reflexive sensation are usually normal in an NMJ. And if it's in the muscle, there's usually some amount of symmetry. So it's usually affecting both sides. It can be proximal or distal. Usually proximal is more affected than distal, but it can fall into one of those patterns we were talking about earlier. Reflexes can be reduced, slightly diminished, but they are usually normal. So that's our second part. We're probably going to be able to localize it from this. Then comes the pattern. Once you suspect, okay, it looks very much myopathic, does it follow one of these patterns which we talked about earlier? If it does, it can suggest to us what type of etiology just from the pattern itself. So on the right, you can see a lot of causes. I'll share the slides with you so you don't really need to look at it for so long because you don't really need to memorize them. You just need to understand there's a pattern. And when you understand there's a pattern, you know where to go from there. Okay. So fourth type is there symmetry, the distribution, the associated features we need to look. So when something sounds myopathic and it's asymmetrical, we tend to think of inclusion body or focal myopathies. If there's any facial weakness, we tend to look hard for them. The usual facial weaknesses we tend to see in a myopathic facies is what we call it, is you tend to see them in chronic myopathies like genetic myopathies, where there'll be wasting of the temporalis muscle. The zygomaticus muscle will be wasted, so you would have a snarl. So that means the angles of the mouth doesn't go up when the patient tries to smile. So that's just clues on describing a myopathic facies, but it's not very easy to see when the first time you look at one. The next thing we need to see is the neck flexors or extensors weak? We need to test them. Sometimes we forget to test these. We could always test the functions and clues at the bedside. We could test the weaknesses, such as are they able to lift their hand and do a combing of the hair action that would tell us if the shoulders are weak. Are they able to stand up from a sitting position from the chair? Is the grip strong? Is the neck flexion or extension weak? Is there any nasal tone to the voice? Is there any reduction in the movement of the palate when we look into the mouth? Is there any ptosis, ocular movements? Is there any diplopia, which suggests ophthalmoplegia? So these are clinical examinations we would do. It doesn't take us very long to do it. And the next is, uh, okay, so from this, we'd probably have an idea that it is myopathic and how do we proceed from here? So we usually proceed by sending the most common investigations. These help to rule out mimics and other things that might um, sound like myopathy, but in actual fact, it's just something reversible. So CK is important. It's most of the time it's usually elevated. You need to look at the reference values in your labs. You can send elderlies if you have it, ALT, LDH. They are good markers. If you look at ALT is located in your cytoplasm. AST is actually, I didn't write AST there, but AST is also located in your mitochondria. So you tend to have an ALT predominant because when you have muscle necrosis, there'll be a rupture of your muscle membranes and your cytoplasm spills out first. So your ALT tends to be much higher. So there are two types of hepatic damage in the liver, which is hepatic apoptosis and necrosis. And in this type of scenarios, in myopathy, you usually have a necrosis. So ALTs tend to be more predominant. Renal function is important. If the urine is dark, it's important to test for myoglobinuria. If it's present, you need to be careful because it will affect the kidney function. Electrolytes are important, especially potassium, phosphate, calcium, because metabolic myopathies tend to be caused and very easily reversible. Thyroid function is important. You won't get them immediately, but it should be sent. cortisol, especially if they are taking things like Chinese traditional medicines or on long-term steroids. Vitamin D. So a study in once showed us that the Malay population had the lowest vitamin D in the PJ crowd, the PJ community that they tested. So it's important. We don't really get much sunlight, and so vitamin D is a very close mimic to myopathy, which is reversible. Autoimmune screens, we tend to test our ANA, ENA. There's a panel which you can send to the lab link. If there's things that suggest polymyositis and stuff like that, you can send your anti-Jo PL7, PL12. A myositis panel is actually available in IMR. Patients on statin, sometimes you'd want to send HMG CoA antibodies. So these investigations are usually done upstairs and not at the emergency level. Then there's that question which usually comes up, should we do EMG, NCS for these patients? So nerve conduction studies are usually normal in myopathies. EMGs are helpful if you're going to do a muscle biopsy. You want to know which muscle is myopathic. Does it have changes? If it has changes, chances you'd see a very good muscle biopsy on that. And if you walk in a neurologist's room and he's doing an EMG, you'd hear him say things like, oh, there's a dive bomber sound, a revving motorcycle sound. Those are typical sounds you get when you stick a needle into a myopathic muscle. And it's interesting to us in neurology when things like that are seen. So EMG is not always needed, but it's helpful. Where imaging is concerned, MRIs can tell you where to biopsy when it shows us muscle edema. Ultrasounds are becoming much more common nowadays. So you can use an ultrasound to actually look for muscle edema and things like that. And it can guide you where you want to biopsy if you're going to biopsy. Muscle biopsies tend to be the gold standard, but you don't really need to biopsy everyone. I've put in a diagram and a chart to tell you roughly what you would see in a muscle biopsy, because if the report reads something like this, you can more or less say it sounds like polymyositis, dermatomyositis. Yeah. So if it has those specific qualities in the histopath. So the question I'm asked usually is when muscle biopsy can be avoided, because some patients don't want to do it, and sometimes you don't really need to do it. So classical dermatomyositis patients with the rash and with the antibodies, you don't really need to do them. Statin-induced immune-mediated necrotizing myositis, you don't really need to send a muscle biopsy. Some genetic myopathies where you have a genetic study done, you don't need to send biopsies for them. Critical illness myopathies in ICUs, especially, you don't require a biopsy for these patients. So there are cases where you actually don't, even though it's the gold standard. That's a take home from this slide. Genetic and metabolic tests are always done in chronic myopathies, and we send them to the genetic specialists in over here, it's in HKL. They send a 500 panel to Korea. I think now they're sending a 350 panel to Australia. If that's out, sometimes IMR has the genetic panels, or you can pay for it, which is very expensive, through LabLink. So genetics is another important factor. It will tell you, it can prognosticate a myopathy in chronic diseases, especially if it's hereditary or if it's a type of metabolic myopathy, you'd know how to treat it. Systemic and malignancy screening, especially if it's an inflammatory myopathy, you need to do this. How you screen them, CT, thorax, pelvis, abdomen, CTTAP is actually ideal. If you're suspecting interstitial lung disease, HRCT of the thorax is important. Looking at the heart is important, especially if there's an NTSRP disease. And coming to the key takeaways, we're near the end. So always start non-invasively. So sense-case antibodies, EMGs are non-invasive, I would put it there. MRIs, muscle biopsy if needed. Genetic screening, serological testings can be helpful. Always screen for systemic diseases or malignancies, especially if there's an autoimmune myopathy suspected. Treatment, I will run through very, very briefly because you don't really need to know too much about it. But what you need to know is there are some general principles we look at when we treat them. First is whether we can identify and remove the cause, which if it's just an offending drug, yes, stop the drug. Something endocrine issue, we can just treat that. If there's reduced inflammation, we can consider corticosteroids, physiotherapy rehab for the muscle recovery, and some medications for bone protection, prophylaxis for infections if you're on long-term immunosuppressants. So this is the basic principles of our care of myopathic patients. Non-pharmacological practices are physiotherapy, respiratory support, bone scans, especially if you are on long-term steroids, vaccines. There's a new protocol out for even patients above 65. Please have a look at that. And finally, treatment based on etiology, specific treatments based on that. So it goes from just oral prednisolone to IV. We have second lines, which we consider when the first lines fail. The drug induced is always stopping the drugs first before we think of starting steroids. Critical illness is early mobilization. So if they're having myopathy in ICU, we try and mobilize them first, and that helps the most. Metabolic, there are lots of drugs which we are out there, especially with certain diseases like Pompe's disease, that newer drugs which have come out recently. Electrolytes are important because if it's low, just correct them and the patients start getting better. And with that, I will end the talk and I'll hope to get some questions. So,
Okay, I think thank you very much, Dr. Vishnu. I think a lot to take back for us in the emergency setting here, compared to what we have been doing previously. So I think for me, what I got back from this is, of course, the relevance in emergency. I think even the duration was acute, subacute, and chronic. So you mentioned that acute was more of myositis, and subacute maybe pointing more towards autoimmune, and chronic more of dystrophy. So that duration itself can give us a clue. And then I think the stepwise approach to localize, is it muscle, localizing it further to see whether it's from the NMJ, etc., recognizing the patterns that you had shown, and then symmetry and distribution, together with assessing the functional level and the screening test. But I think in the emergency, the screening test would be more of blood tests and referring for EMG or NCS. I think the other example, the ANAs, etc. I'm not sure if we are able to send that from the emergency setting.
yeah, so
Yeah,
most of the screening would be done upstairs.
right.
What you except for the metabolic screen, which you need to do, which is all your calcium, magnesium, phosphate,
Yeah,
and
the CK thyroid
like
function.
like I stressed the most, yeah, CK is also important. If you have elderlies, it's also important. If you could send that as well, it can give us a good idea. And like we stressed, the history is very important because we always tend to forget drug history, family history, those things. And post-viral myositis and myopathy tends to come in quite a lot with the influenza outbreak. We tend to see those things, and they can even cause metabolic myopathies post-viral. Yeah.
Right. Okay. We open the floor to some questions. So I see a question in the chat. Let's go there first. Which type of myopathies is usually most common in Malaysia from your experience? So is it most commonly
Okay.
endocrine, infection, drugs? To try
Thank you.
to narrow their flow of thought. What do you think?
Okay. So because I am in Putrajaya and we are a hospital of rheumatology, we see a lot of systemic myopathies, so autoimmune based. So that's our bulk of cases, but they're not the most common. So the most common, I would still say metabolic myopathies that they tend to be more common and drug induced because people tend to take in Malaysia, especially outside in Penang, we got a lot of drug induced from Chinese traditional medications and things like that. So depending where you are, that's the most common, but we don't have a demographic to say what's the most. If you look at the international demographic, they tend to say the chronic myopathies tend to be the most common ones that present. So I don't think that's so common in Malaysia because every neurologist would be able to count with his fingers the amount of chronic patients he's probably seen in a year.
Mhm. Okay, thank you. Thank you very much for that clarification. Another question, apart from difference in terms of fatigability, any other signs to differentiate NMJ and myopathies in general? I think you mentioned fluctuation, maybe
Yeah.
one
So
of the symptoms there.
fatigue is very subjective and sometimes not so easy to do if it's a proximal muscles because your proximal muscle is big, so you can't fatigue it so easily unless you know how to do how to fatigue the. If it's an ocular problem, it's easier to fatigue. You can do an ice pack test and you can reverse the fatigue, but fluctuation is the big key. So the patient will be able to tell you, yes, in the morning I was a little bit better, or in the evening or sometime throughout the day I was better. So you might think why some myasthenia gravis patients tend to say I was better in the afternoon, not the morning, because we attributed the ptosis to REM sleep, but that's a different topic altogether. So as long as there's fluctuation, you tend to think it's an NNJ problem, and fatigue is a good ancillary clinical test, not a direct test.
I think
Yes.
that clarifies it. Let's open the floor. Anybody else has any other questions? If not, I would like to ask one. We in emergency tend to give steroids for acute inflammatory disease causing, example, neuropathies. What is the role of steroids here? Is there any role of routine steroids in these kind of cases? Because, for example, in the emergency, we will send the electrolytes, definitely CK, and try to rule out these kind of causes. And if we can't really find, then sometimes there is a tendency to give the steroids. What is your opinion on?
Yeah, I would think it's a little bit dangerous to start some of them on because some of the general practitioners start them and say, okay, maybe you need a small dose of prednisolone for a week and stuff. And if it is not an autoimmune based myopathy, you can sometimes worsen it. So I wouldn't start just like that. I would have something to say that okay, it might be. And CKs tend to be a sign that there might be some muscle inflammation that may respond to steroids. So CK is high. Something if you have elderase, I told you that's a nicer enzyme because an increased elderase level with paired with your CK tells you there's muscle necrosis, and we tend to see them respond well with steroids. Yeah.
Sure. Okay, that clarifies it. So no routine steroids.
No.
Okay, all right. Okay, sure. Let's open the floor. Any other last minute questions from anyone?
There is a question in the box, I guess. Huh?
All right. There's a question in the box. Can you tell us when to refer to neuro team to be seen in emergency, or can we be sent to the clinic according to usual appointment, apart from physiologic anomalies, example, airway?
No.
So let's say there is no emergency
So
situation there. Would the patient better be seen in the clinic, or when to refer to the neuro team?
yeah,
Whether you want to refer them to see in the emergency or in the clinic.
this is actually a good question. So my first rule is when the myopathy is acute, the less than 7 days, I would say refer because that is a red flag by itself. If there's myoglobinuria, yes, refer. They need to get into the ward. We need to manage. If he's got cardiac or respiratory symptoms, refer. Apart from this, everyone else can be seen in the clinic. A bit of proximal weakness, can't get up on and off, a bit of myalgia, arthralgia, and they're well, no red flags. Yeah, refer them as an outpatient. No necessity to admit these patients. Hmm.
Okay, I think that clarifies it as well. Acute diseases, less than 1 week, then definitely from the ED, otherwise to the clinic. Okay, thank you. Any other questions? Any
Uh,
other?
I have a question.
Sure,
Hi,
sure.
Vishnu.
Proceed.
Hi.
All right. I want to ask you something. If the creatinine kinase is negative, it still does not include myopathy. Do you agree with me?
Okay, so CKs are not exclusively the test for myopathy. That's why I kind of mentioned elderlies in the
Mm-hmm.
beginning, but sometimes in chronic myopathies, CKs can be normal. In steroid-related myopathies, it can be normal. In inclusion body myopathy, it tends to be normal. Critical illness, it tends to be so. There's a big umbrella where CK is normal. CK just tells us it's an ongoing muscle destruction from inflammation. That's all it tells us. So we would, if you can pair it with elderlies, that means a normal CK with high elderlies, we can still say there's an inflammatory process going in, and to us, that looks very much like a dermatomyositis, an autoimmune inflammatory cause. If the CK is high with elderlies, it tells us muscle necrosis. If it's normal with a normal elderlies, it is probably a chronic myopathy, about 90% of the chance. So CKs, it is a very useful tool for us, but it's not a diagnostic tool.
Mm-hmm.
And acute myopathies, it's important because very, very high CKs will cause your rhabdomyolysis and all that. So that is a good marker to tell us how much is improving and when we can let him go.
Mm-hmm. Sounds good. One more question. Can you tell us a little bit more about inflammatory myopathy? Like, how do they present with?
So most inflammatory myopathies tend to present proximal weaknesses. That's the pattern that they come in most of the time, and it's in the limb girdle type of distribution. Some of them would have proximal arms and distal legs, but the most common ones we see is proximal muscle weakness with a head drop. So you'd always see them coming in with that, and they will say, very hard to comb my hair, very hard to walk up the stairs. That's the most common presentation all the time we see. So I would say that and when that's for us a small red flag to say, oh, it's proximal myopathy, and
Mm-hmm.
that's inflammatory myopathy. And yeah, that's the most common, and that's the thing you should look for when they are having myalgia, arthralgia. I'm not arthralgia, myalgia. Yeah.
Mm-hmm. So, because of the word, does it, if is it inflammatory, so does it cause a raise in CRP?
No. So some
Um,
say it's a misnomer, but when you look at the biopsies here, there are inflammatory cells. So I wouldn't really call it a misnomer. Like some talks you see them saying that, but it's not. But it does not affect the SIRS and those kind of things where your inflammation tends to CRPs and ESRs tend to go up. Not all the time unless there's a systemic involvement, like an underlying as a connective tissue disease, then you might have some changes in the ESRs. But no,
fair
I
enough.
think that was, yeah.
Thank you.
Okay, we have got one more question. Thank you for the talk, Dr. Vishnu. The patients with known myopathy, what are the critical emergency care considerations to prevent complications that may arise from stroke-like symptoms? So, patients with known myopathy, what are the critical emergency care considerations to prevent complications that might arise from stroke-like symptoms? What is your opinion?
It's a very confusing question. So if let me just see if I got the question correct. So if someone has a chronic myopathy, you want to know how to prevent this patient from having stroke-like symptoms. Is that correct? Is that what you understand from the question?
I think
So
Dr. Mohanis, maybe you can clarify if you want. I think,
Hi,
yeah.
sorry. Yes. So basically, how can how can we differentiate those weakness from stroke-like symptoms and
okay,
purely from myopathy, but
okay,
underlying myopathy, they are already having
okay.
myopathy. Yeah.
Okay, I understand the question. Okay, so yeah, so I think what she's asking is if someone comes in from weakness, you want to just eyeball it and say, is this a stroke or is it from the myopathy itself? If
Yes.
especially if it has myopathy, is this new weakness a progress or is it from something new like a stroke, right? So
Mhm.
the first thing you need to know when you have a stroke, that is an upper motor neuron lesion, and the type of weakness you get in an upper motor neuron is a pyramidal sort of weakness. So if our myopathic patient comes in and he says, my weakness, so a pyramidal weakness, the easy way to remember is try to picture a stroke patient. His upper limb is, he's flexed at the elbow, he's abducted at the arm, and wrist is flexed like that. So all this is because the flexors are stronger than the extensors. So if a myopathic patient comes in and his upper limb flexors are stronger than its extensors, that means it's a pyramidal type of weakness. The next thing you look for is the reflexes. Does it point to an upper motor type of lesion? Early strokes wouldn't because of the spinal shock part, but later it would. Is the tone increased? If the tone is increased, there's some spasticity that suggests an upper motor lesion. And how we know the tone has increased, we compare the left and right. So strokes always come in as a hemiparesis, so one side will always be different than the other. And the lower motor, in the lower limbs, you need to know the extensors are stronger than the flexors. It's the opposite. So pyramidal weakness is a very good sign to tell us whether the weakness he's coming in with now is progressively from an upper motor neuron region, or is it just from the myopathy getting worse because of a viral infection or something like that? Yeah, hope that answered that.
Okay, all right. So strokes more of upper motor neuron presentation compared to the myopathies. Any other questions? I think that's all for the questions. So I think thank you very much, Dr. Vishnu. I think very enlightening talk also for us in the emergency.